right, greetings everyone. This is Dr. Cameron Dezfulian from Baylor College of Medicine, and today I'll be talking to you about ICU monitoring. We're going to divide this lecture into two parts where hopefully I'm going to go over some of the principles of monitoring and the applications and also lay out some of the pitfalls. And we're going to start today with talking about respiratory monitoring, which I'm going to divide into pulse oximetry, end-tidal CO2, and then some of the waveforms on ventilators. So let's start off with a question. You have a 7-year-old with a 3-day history of right lower quadrant abdominal pain and anorexia who presents febrile, tachycardic, hypotensive, is given a fluid resuscitation and started on pressors, which quickly escalate up to 0.5 mics per kilo per minute to maintain mean arterial blood pressures. His SpO2 on all the extremities is unmeasurable or gives you just fluctuating values that you don't believe. What is your immediate response? A, do you disregard the SpO2 because it's useless in shock? B, do you replace the probe onto the earlobe or the forehead? C, do you obtain a blood gas for accurate saturation values from the actual measured arterial sat? D, do you place an arterial line for serial blood gases? Or E, do you resuscitate the patient better to get an accurate SpO2? And so the correct choice here is B. And actually getting to the kind of explanation of this, it's not that C, D, and E are incorrect. They actually are all correct. However, they're just not the quickest thing, right? So, you know, if you move the pulse ox probe to the forehead or the ears, which are better perfused areas, and as we're going to talk about, the pulse oximetry needs perfusion to be able to work, and you still don't get a value, then you would have to do something like place an arterial line and get measurements that way, because you have no other way of knowing what the SAT is. Obviously, the quick way to address this is to try to go to a more perfused area, which is why B is the right answer. So this is just the intro to pulse oximetry, and pulse oximetry is based on the principle known as the Beer-Lambert law, and what that principle is that you can measure the concentration of a solute if you know the path length and the absorption of light. And the solute in this case, or solutes, are oxy and deoxyhemoglobin, which are what we're measuring with pulse oximetry. And we're doing that by using a combination of infrared and red light. Okay, so the important distinction here is that oxygenated hemoglobin is mostly going to capture the near infrared, whereas the deoxygenated hemoglobin is more going to capture the red light. And so the pulse oximeter basically puts together the red versus infrared ratio, and based on that comes out with the SpO2. Now the important thing is that there's absorption of red and near infrared light by your tissues as well, and by other forms of hemoglobin. So what the pulse oximeter has to do to distinguish what is venous and what is tissue from what is arterial is look for the actual pulsatility. And so that's the portion that it's going to measure. So if there's not pulsatility, hence if there's not good perfusion in the area you're measuring, you don't get accurate values. So this is just a picture, and I think everybody's familiar with what a pulse ox looks like, but inside of that sticky or that metal probe that's on the finger, you have a light emitting diode with a photodetector on the other side. You place it usually on a finger, and then you've got the red and near infrared that are being measured. You know, the ratio is being calculated by basically seeing what is the peak absorption at these two different wavelengths versus what the baseline is. And here's a nice figure that I think goes through the different components of the pulsatile versus non-pulsatile. So here in A, what you're seeing is that there's, as I mentioned, an arterial component where the arterial blood has this alternating current where the absorption is changing as pulsatility occurs, whereas you've got this stagnant component that is considered the direct current component, which is a venous and capillary blood as well as stationary tissues. What the pulse ox does is essentially ignores this DC component and just focuses on the AC component. Okay, so when you look at it differently, you could think of kind of the change from systole to diastole as being that AC component, and then the constant, which is whatever is the baseline diastolic blood pressure on top of capillary and venous blood flow, is the direct current and just gets ignored. And so that ratio then of red to infrared is what is used by the pulse oximeter. And you can see that as the red signal gets relatively higher compared to infrared, it's read as being more desaturated. And as you get to have more of a near infrared component compared to red, now all of a sudden it's read as higher saturation. So because of this dependence on the alternating current or the pulsatility, whenever you have a low perfusion state, you just get very low amplitude pulsations, and you'll see it on the pulse ox waveform. Some pulse oximeters actually give you a number that's associated with it that tells you kind of the quality of the waveform. But the point is that if you don't have a good waveform, you can't really rely on your values. So what is going to give you poor pulsatility? Vasoconstriction from being hypothermic or being on really high doses of pressors, loss of blood flow because you have a thrombus or emboli or a tourniquet applied to that particular extremity. And then when you're dealing with just global hyperperfusion, so really shocky patients, sometimes you just can't get measurable values. So definitely I've encountered cases where nowhere on the patient's body, because they're in such bad shock, is the pulse ox accurate. In those situations, you just unfortunately have to depend on serial blood gas values, and that's all you have. It's important to distinguish between co-oximetry and pulse oximetry. So pulse oximetry is the 2-wavelength system that we use for monitoring, based on the principles I just showed you. Co-oximetry, on the other hand, will actually look at 4 wavelengths or sometimes more, and based on that be able to distinguish different types of hemoglobin. So here what you're seeing is the absorption frequencies of different types of hemoglobin, including methemoglobin and carboxyhemoglobin. And what you can see is that, if you're just measuring the red and the near infrared, it becomes kind of challenging to separate these out, right? So specifically, carboxyhemoglobin looks an awful lot like oxyhemoglobin on the red side of things. They're quite different on the near infrared, but it's this kind of strong red signal that the pulse ox hones in on, and that's why a pulse oximeter tends to think that somebody with a lot of carboxyhemoglobin is 100% saturated. Meanwhile, methemoglobin, you'll notice, has an absorption of red that's similar to deoxy, but then a higher near infrared signal. And so as a result, the saturation is not quite totally desaturated, but it's also not saturated. So you end up moving towards 80-85% saturation when you have a high methemoglobin content. And so this is just problems with the absorption. And you can imagine that if you had a couple more frequencies in here, you would now be able to discern between these different types of hemoglobin. And that's what co-oximetry is a few more wavelengths. So when we talk about saturation versus fractional oxygen proportion, saturation is that SpO2 value that the pulse ox is reporting, right? And so in this example right here, this is a patient who, for example, has 20% deoxygenated hemoglobin and 20% carboxyhemoglobin and 60% oxygenated hemoglobin. If we talk about the saturation, the SpO2 value or SaO2, it's 75%, because really all we're doing is we're saying that 60% out of a total of 80% is saturated, right? But if we're looking at the fractional oxygen or oxyhemoglobin content, it's 60%, because now we take all three. So in a way, it's almost like when you're talking about the saturation, you ignore some of these other forms of hemoglobin that the pulse ox is not really able to pick up on. So the fractional hemoglobin concentration, to get it, you really need technology like co-oximetry to measure, whereas the pulse ox is going to give you your saturation. And depending on what type of blood gas analyzer you're using, if you're using just simple cartridges, you don't have co-oximetry built in. So you're actually getting an SaO2, not an FO2 hemoglobin. On the other hand, if you use one of the more larger devices that's sitting on a benchtop, you're going to get the actual fractional, which is going to allow you to distinguish things like met and carboxyhemoglobin. So what are some of the causes of falsely elevated or depressed SpO2? So here, this table just summarizes for you. So I spoke about how methemoglobin and carboxyhemoglobin affect things. The effect of anemia is an interesting one. Ultimately, you get less scattering because there's less blood cells, and so the machine has kind of a compensation for scatter, and because there's just less of it, it falsely reads the saturation as being higher than what it actually is. And really that's only true in hypoxemia. So in other words, when your patient's hypoxic, you tend to miss that if they're really anemic. On the other hand, if they're normoxic, it'll still look normoxic, okay? In the case of falsely decreased hemoglobins, methemoglobin tends to verge towards 80 to 85. So early on, or well, depending on what the patient's true oxygen saturation is, it may be either overestimating or underestimating. It just depends if you have a saturated or desaturated patient. Methylene blue and really any other dyes, there's some weird ones in there that I'm not going to get into, but if they are being absorbed in the red or infrared spectrum, they're going to throw off your pulse ox. And then patients who have really profound venous pulsations, so some of our Fontans or patients who have significant liver disease and you're getting saturations where you're seeing the venous pulsations, they're going to actually give you values where the venous, which obviously is desaturated blood, is being read by the machine as being the pulse, right? And so as a result, you're going to get a depressed oxygen saturation when it's not really true. The final one, patient movement, is just because anytime the patient's moving, the machine takes that movement to be potentially some of the pulsatility and then starts reading the absorption of things like the venous component and the tissue components as being part of the arterial component, which obviously it isn't. And so you decrease things. So as I mentioned, the gold standard really is co-oximetry that uses 4 wavelengths and gives you a oxyhemoglobin fraction, and that's the real way to be sure if there's questions about things. This paper came out in the New England Journal a couple years ago about racial bias, and we're talking about bias here. We're not talking about like unconscious bias. The pulse ox obviously doesn't have a brain, but we're talking about bias in the sense of just statistically, there is a difference between black patients and white patients. And what becomes important here is you can see that when you're moving towards lower saturation, so this is the arterial oxygen saturation that of the actual patient, and then this is by blood gas, and then this is what it is by the pulse ox. And what you can see is that you have a large proportion of black patients, so that's the ones that are in red, who actually are desaturated. So they're falling below kind of the 88% line, and yet the pulse ox is reading them at relatively normal saturations, 89, 90, 91. And that's because this technology ultimately, when it got calibrated on mostly white patients. And so, difference in pigmentation, this is black and white, but there are subtle differences with patients who are Asian, who maybe their skin color is a little bit more yellow, Latinos who might be more tan. The point is that any pigmentation can potentially throw off the pulse ox a little bit, and just recognize that the validation work and the calibration is mostly done in white patients. So that can lead to, in some of the extreme cases, significant desaturation that's flying under your radar.